I would like to call the chairpersons, Dr. Satyapriya Sarkar, Dr. Gautam Das, Dr. Debottam Bandhpadhyay, and Dr. Samir Baliga. Please join us on the stage. Thank you.
Good morning, delegates. Welcome to the 32nd National Conference of IASG. We are going actually before time, a rare situation here. And without wasting any more time, I request first Professor Mahesh Goenka to talk about poem, The Nuts and Bolts. He is a man who doesn't need any introduction in the global territory anywhere, keeping Kolkata in the global leaders. My inspiration, dear sir, stage is yours.
Good morning, everybody. Thanks for those kind words. It's really unusual to see a program going before time. I must thank the organizers, in particular Dr. Sanjay Mandal, for asking me to be here among the surgeons. Though the gray zone between the surgeon and the medical gastroenterologist is gradually disappearing. I have taken the liberty of going a little beyond the dictate which was given to me by the scientific committee. The basic idea being that there must be a take-home message for whoever is present here, rather than sticking exactly to what the talk is. Can we start with my first slide and the audio as well? I've incorporated the audio in my recording. Let's see how it runs. If the audio works, is fine, otherwise I can speak.
Poem, usually called, was first invented by Indian gastroenterologist practice in USA, Dr. Chairpersons, and the first human case was done by Professor Inouye from Japan. Poem is actually a third space endoscopy, by which we mean we are working at the submucosal level in between the mucosa and the muscular layer. This is done by creating a mucosal flap after incising the mucosa. The principles of poem are shown here. The first step is incising a mucosa in the distal esophagus, creating a submucosal tunnel with the help of the endoscope, starting a myotomy in the esophagus, a centimeter or two below the mucosal incision, and then extending downwards to involve the gastric muscle close to the cardia, and then finally closing the mucosal defect. The case under consideration had achalasia cardia type 2 shown high resolution manometry. Compared to the normal high resolution manometry, as shown in the right picture, where there is a nice peristalsis and an intact LES pressure, here in this patient, there is no peristalsis, LES pressure is increased, and there is pressurization in the body. Poem was initially done for type 2 and type 3 achalasia, but now poem can be done in all three types of achalasia, irrespective of the age of the patient. Can also be done as a redo procedure after failed pneumatic dilatation, Heller's myotomy, or previous poem. The equipments required for poem are shown here. So there has to be an endoscope with a cap attached to the distal end. And this cap is an important component because it prevents the contact between the lens of the endoscope and the tissues you're working at. That prevents the red out. You use a carbon dioxide insufflator rather than room air. The submucosal tunnel is injected with methylene blue either with the help of a needle with syringes or by the water jet system incorporated within the energy device. You need hemostatic mechanisms, including this coag forceps to control bleeding, and then you require clips of one of the types to close the mucosal defects. The knives which can be used for poem are shown here. I have used the first two. Speedboat is a relatively recent knife, and I do not have any experience. The hybrid knife or T-type knife is a complete knife which can do a coagulation, cutting, and can inject with the help of a water jet through a channel incorporated within the knife. Triangular knife has a triangular shape at the tip which allows equal distribution of the energy around it, mounted on the knife which is 4.5 millimeter in length. The setting for energy delivery is individualized. I use endocut Q effect 2 and a forced coagulation effect 2 with a maximum watt to 60. Patient position can be either supine or lateral, and both produce a similar result. I prefer a supine position because I feel that the anterior posterior wall orientation of the esophagus is much better. Your endoscope and accessories are in the neutral position, and more important is that any complications like pneumoperitoneum can be easily diagnosed while the patient is supine. The initial endoscopy is called mapping upper GI endoscopy, which is to identify the various landmarks. In this case, you can see a spinal projection here. And then you reach the G junction where you find some resistance because of the achalasia, and then you cross the G junction to reach the stomach. Once you are in the stomach, you retrovert to look at the cardia from below, and any fluid or debris in the stomach or the esophagus is cleared to prevent contamination of the operating area. Next step is to choose the point of injection. One can do an anterior poem where you inject at 2 o'clock position of the esophagus, or a posterior poem, which I prefer, where we inject at 5 o'clock position, a little to the right of the spine. I prefer posterior poem because I find it technically easier, though the results with both anterior and the posterior poem are almost equivalent in most of the studies. So what I'm doing here is injecting about 15 to 20 ml of methylene blue at the site of my preference in a relatively avascular mucosal area, and raise a nice bleb which acts as a buffer between the mucosa and the muscle layer. So once the bleb is reached, then you incise the mucosa 2 to 3 centimeter using the same knife, a clear cut, and this is the point of entry of the endoscope. Now this is the most important step, or the rate limiting step in understanding the techniques of poem. Once you make a cut in the mucosa, you underline, you dissect the margins on both the sides beneath the mucosa. The idea is to create a space for endoscope of a diameter of 9 millimeter to enter the submucosal tunnel. This cutting on the margins are very important because otherwise one may struggle to enter the submucosal tunnel. The next step, of course, is to create a submucosal tunnel, and this is done by movement of the knife. You don't move the knife alone, you move the scope along with the knife by torquing the scope and moving it either clockwise or anti-clockwise. The idea is to keep the dissection closer to the muscular layer rather than the mucosal layer, because you don't want to damage the mucosal layer. A little damage to the muscular layer is fine because that's the ultimate aim. You're going to do a myotomy subsequently. So you proceed step by step, every centimeter by centimeter. You can see a little injury to the muscle layer, doesn't matter. You inject intermittently methylene blue, and then you cut from one side to another side. Now, this is again very important, that if you find a small vessel, you can just coagulate with a normal knife, but if you find a vessel of large caliber as in this situation, then you coagulate with a coag forceps at an effect of 6 or so, and then you make this vessel obliterate. You may have to repeat this procedure 2 or 3 times to completely prevent bleeding to take place. However, if the bleeding happens, as is shown here, then you can again stop the bleeding by using the coag forceps over the site of the bleeding. You must do it fast before the area becomes very messy. Hemostasis achieving is a very important component of a successful poem. Now, as you proceed downwards, you identify the G junction, which is shown by these palisading vessels you can see all around. You can measure the distance from the mucosal incision to identify whether you have reached the G junction, and the space there becomes much smaller. So now the tunnel is ready. So next step would be to perform a myotomy. Now we start the myotomy almost about 2 centimeter distal to the mucosal incision. Here you can see I am cutting the circular muscles, and once you cut the circular muscles, the longitudinal muscles which are deeper becomes exposed. Longitudinal muscles are not very tightly knitted, and they separate out as you cut the muscle there, as you can see here, and the mediastinum is partly exposed. There is confusion as to what is the best method of performing the myotomy. Some people will perform only circular muscles, some will do a partial thickness myotomy. What I do in my practice is that initial part Proximally, I cut only the circular muscle, but as I go towards the G junction, I would cut both the circular muscle and the longitudinal muscle. The poem myotomy has an advantage that the two cut areas separate out and retract very easily, and so the mediastinum is clearly exposed in this situation, as you can see in this segment of the video. How long should be the myotomy? How long should be the myotomy is an important issue. For usual achalasia cardia type 1 or type 2, a short myotomy is enough, 3 to 4 centimeter in the esophagus, 2 centimeter in the cardia. For type 3 achalasia, we usually do an extended myotomy. This is tailored according to the length of the compartment pressurization on the high resolution manometry. For category 3, which is LES preserving myotomy, can be used for jackhammer esophagus and distal esophageal spasm. I think the last very important step for POEM is mucosal closure. One has to do a very good closure, and you start by putting your first clip on the normal uncut mucosa distal to the mucosal incision. This approximates the two retracted end of the mucosal incision, and then you apply clips one after another from distal to proximally. Depending on the length of the mucosal incision, you may require from 4 to 8 clips. The closure can also be done by over-the-scope clips and can also be done by suture device, which is used for bariatric endoscopy. Now, capnoperitoneum, which means carbon dioxide in the peritoneal cavity, is very common, almost happens in about 50% of the cases. Nothing to worry. Usually it does not require any treatment, but if there's a ventilatory compromise, then you can take out the carbon dioxide by putting a needle in the peritoneal cavity. Now, post-operative care, strict nilparoroli, IV antibiotics, which should be continued for some time in an oral form. Antiemetics, PPI to continue, liquid diet for 3 to 5 days. Now, this is how the manometry improves in 3 months. You see some peristalsis come back and the LES pressure is improved. Now, this is a poem which I did just about 3 days back, and I'll just show you in a short abbreviated video over 1 minute. The patient is supine. This is the initial endoscopy to decide the site of injection. Now I'm creating a bleb, as you can see, by injecting methylene blue. And after that, an incision will be made on the mucosa. As you can see, 2 to 3 centimeter long. And then you enter the submucosal plane, do the submucosal tunneling by moving the Urbe knife, as you can see, but this is by clockwise and anti-clockwise movement, moderate sized caliber vessels controlled by coag forceps. And then you complete the submucosal tunneling. You identify that the completion has taken place by retroversion in the stomach, and you can see the blue color, and then you do a myotomy followed by closure. POEM efficacy has been shown consistently to be more than 90%, has been shown to be better than pneumatic dilatation with a treatment success of 92%. And there are studies which have compared it to Heller's myotomy with similar success rate, shorter procedure time, fewer side effects with slightly increased GERD rate. Thank you very much.
So that was a short video. I'll be ready to take questions either now or maybe after the 3 sessions. Doesn't matter.
I think we please go on with the questions, and we are very grateful to you, sir. Despite your very sensitive family responsibility, you came and gave your lecture. Please, I think fantastic teaching video. So any confusion from the chairs or from the audience, please go on.
Dr. Bhartiya. Your mic is not on.
Hello. One is how far up in the esophagus you go and how far down in the stomach you go.
There are 2 questions or the 2 parts of the same question?
One question, yes.
Okay, very good question. I think this is what we decide beforehand. I tried to show that in a quick slide. that we do a manometry beforehand, and in type 1 and type 2 achalasia, we don't require to do a large myotomy, 4 to 5 centimeters proximal to the G junction and 2 centimeter distal to the G junction is what we do. The question is mainly the type 3 myotomy, 3 achalasia cardia. You need to do much longer myotomy, and now we have high resolution manometry to tell us that what is the spastic component of the pressurization. And depending on that you decide, and usually it's much longer, maybe about 10 centimeter, 12 centimeters also. So trend is going towards from more longer myotomy to shorter myotomy now. So as I said, it will depend on the achalasia cardia evaluation by manometry. It has been, people have tried to do a shorter gastric myotomy to reduce the reflux, but it has not been found to be making any difference. So to reduce the reflux, now what we do is that when we approach the G junction, when we are doing a posterior myotomy, we get oblique fibers, which is a part of the sling which forms. So we avoid cutting the oblique fibers, and we cut the circular fibers a little away, a little to the right of the oblique fibers, and that has been shown to reduce the reflux rate after the poem. There are recently, last 2 years, data in which I would call it extreme endoscopy, that you do a myotomy at poem, and then you do a transmural entry into the extramural space and do a wrapping around the fundus to prevent, to wrap around the G junction. I think it's an evolving technique, again started by Professor Inouye and his upcoming technique, but I don't have long-term results to talk about. But these are some of the issues, some of the modifications which are being done to reduce a small amount of increased reflux with poem.
The second question is, then when we do the open myotomy, we make sure that the muscle is separated from the mucosa at least half of the circumference of the esophagus. Here you are not doing that. The reason for doing there is that there is a chance of recurrence. So do you think that is going to cause you recurrence?
See, I'll tell you that whatever myotomy we have done, and we have done quite a bit of them, almost about 40% of the mucosa is separated out. When you inject and you are moving from one edge to another edge, almost about 40 to 50% of the mucosa is being separated out. You may be entering at a particular point, but you are creating a tunnel by injecting. So that's not a major issue. So far as the recurrence is concerned, I would say now there are about 4 years data after poem and a large number of series from Professor Inouye and also from some centers in India, which has shown that the long-term results are very good. So I don't think that's a major issue. Now, if I know I'm talking about the surgeons, but then you have to also understand that the surgeon operates, you're going through the hiatus. We are not going through the hiatus. So we are possibly, if I can say that, not damaging the whole mechanism as much as surgeon needs to do. So there are advantages and disadvantages. There's NEJM paper, which is an excellent paper on a large number of patients, more than 200 randomized to two trials, have shown advantage of poem in terms of shorter time, less adverse effect. Overall G reflux is also the same, but if you look at mild esophagitis on endoscopy, it is higher for poem in the initial phase compared to Heller's myotomy. So there are advantages and disadvantages, but I think it's an evolving technique, and very soon we will have a situation where we find it to be better than Heller's in all aspects.
Thank you.
Thank you, sir, for that excellent video lecture. What about end-stage achalasia? What are the results with poem, and what would you recommend if a patient comes to you?
So I think by end-stage achalasia, we are usually meaning sigmoid esophagus. I think this is a little more challenging, and that was initial days we considered to be a relative contraindication, but now no more. You have to evaluate beforehand, and this is one situation where barium may be useful. Usually don't do barium, but barium may be useful to understand the anatomy. If it's a 90-degree angle just above the G junction, then I would possibly ask my surgical colleague to go ahead. But all sigmoid esophagus are not 90 degree. So if it's less than 90 degree, I still may do it. I may modify my technique a few things. One is that there is a chance of losing the axis. So I'll come back again and again, enter the lumen and ensure that I'm in the right track. And many people put a guide wire inside the esophagus, which can be visualized from inside the tunnel to know that you are in the right axis. I think the major problem is that you may lose the axis. So there are some technologies which are being done, but if it's a 90-degree angle, I would possibly hand over to Dr. Bhartiya or to other colleagues.
In Hellards, we routinely do a fundoplication. So endoscopically, do you add a fundamental procedure?
You do a fundoplication because you work on the hiatus much. We usually don't do fundoplication, but as I said, we do technologies which avoid damage to the sling muscles. So we can identify, I had a slide, but Dr. Mandal gave me exact 12 minutes. He says you cannot escape beyond that. So we identified the oblique fibers when we reach the G junction, and there are two landmarks, two vessels which come at that oblique fiber. So we avoid the oblique fibers, go a little to the right, don't cut the oblique fibers. It has been shown definitely that it reduces whatever risk of GRD is there. People have done, as I was saying, that fundoplication has been added as a notes procedure to endoscopic procedure, that you cut through and then create a wrap by putting a sling around the fundus. There is a gentleman called Dr. Amol Bapai who would be here, I have seen in the program, who is an expert in doing that fundoplication as an additional procedure. He is an expert. This fundoplication was again started by Professor Inouye, who is a master of doing poem. He has now an experience of about 700 poems done over a period of time.
I think no more questions for this, Dr. Goenka, what I've told. Excellent speech, sir.